Hi, welcome everyone. Thank you for joining us for today's Facebook Live Forum. My name is Amarjit Kaur and I'm from the Marketing Department of our Damansara Medical Center. So today we are discussing about ACL 101 with Dr. Gandhi. Our presenter today is a consultant orthopedic and sports surgeon, and he has been with ADMC for the past 3 years with a special interest in sports injury. Welcome, Dr. Gandhi.
Yeah, thank you, Sonia. Thanks for the invite.
Thanks, Doctor. Thanks for having us, actually. So, Doc, let's jump into ACL right away. So, What is ACL and what does it do? Or maybe you want to share something a little bit about ACL? Maybe
not much. ACL is my favorite ligament. So the ACL is an acronym for the Anterior Cruciate Ligament, right? So now the ACL is one of the a few ligaments, important ligaments within the knee joint, and it serves, of course, a variety of functions. So in the ACL, its primary function is to stabilize the knee. All right, in particular to stabilize anterior translation. Now that's a very fancy way of saying we don't want your shin bone to go too far in front of your thigh bone. Okay, so it keeps it in that position. The ACL also has a secondary function. It also supports the knee in rotation. Okay, and among the other things that the ACL does, and very importantly, it also acts in part of our neuro coordination. It has proprioceptive fibers. So these fibers actually help tell your nervous system where your knee is in space. So there's a lot of functions. And the main thing is it stabilizes the knee joint so that you can walk, you can run, you can jump, you can do all kinds of things humans do in a nice, stable, safe manner.
All right. So other than that, what are the causes of this? What are the problem that is the patient would face with this injury?
All right. So if you're talking about a tear of the ACL, okay, so you're somebody who injures the ACL, of course it's a painful thing, nobody likes tearing the ACL. So when you injure it at the first instance, it's normally because we commonly see it in sports. You have this painful pop. Some people feel or hear a pop. You get some swelling within the knee quite early. And then at the early instance, swelling, inability to walk, inability to move or straighten your knee. So it is a very uncomfortable thing there.
Okay.
And now, when the swelling does settle down, because the ACL, if it is torn, then it is unable to perform its function. Then what the patient is left with is without a functioning ACL, they feel unstable, or in layman's terms, it feels like it's giving way. They don't trust their knee when they're running, when they're moving, and especially when you're turning, especially in pivoting sports like rugby, football, basketball, and stuff like that. There's also a few other things that happen when an ACL tears. The remnant, or whatever is left, sometimes if it behaves itself, it's okay. But in most cases, it actually acts as a third body. So it starts, causing jamming or locking of the knee. That in itself causes pain, especially when you're trying to straighten your knee fully. And not to forget, remember, to tear your ACL, you need an injury to your knee. ACLs don't often just tear on its own. There's a few of its friends, the other structures within the knee that gets torn. Commonly the meniscus, but also other associating parts of the cartilage, and also in very bad cases some concomitant ligaments as well. So that's why you need to get that checked and assessed properly if you're dealing with it carefully.
Okay, so is this a problem only for those who are active in sports, or any common person can get it?
Well, yes, it is commonly seen in sports because that is the time when you actually subject your body to this kind of running, stopping, cutting movements, right? So it is common in sports, particularly in, as I said, pivoting sports like football. You see a lot of football. Any sports. I've seen it in sepak takraw players, volleyballers, Malaysian skiers, downhill skiers. I didn't know Malaysians were that many skiers. You also see it in people that jump, sportsmen that do basketball and volleyball and stuff like that. Now, to answer your question, Sony, no, it's not just athletes. You also see it in falls, common falls. People falling down the stairs, people falling off from a stool. I got one patient just about a month ago. Was standing on a chair, picking up something. The chair fell off, and he fell and landed awkwardly on his leg. The other thing, Malaysia, we got nice roads. Unfortunately, we also get a lot of road traffic accidents. And quite fair, most of my complex ACL, and these normally they happen together with other ligaments like PCL, MCL, knee dislocations. These are motor vehicle accidents or high level energy trauma. So to answer your question, yes, it's common in sports people, but it's not exclusively a sports issue. It can happen to anyone.
Okay, so Doc, normally how long does it take the recovery? How long does the recovery take actually?
Good question. So if you're talking about recovery, are you talking what, before or after surgery?
Both.
Okay,
if the patient does not proceed with the surgery, so how long is the recovery post?
So that's a very good question. The question is, I tore my ACL. I get a cut on my hand. It'll heal in a few days. Now the ACL, just the ligament per se. Now, if you want to look at the biology of it, where does it tear? It normally tears in the mid junction. Now this inherently is a problem. The biology of the ACL is such. Mind you, you must first understand where is the ACL. The ACL is between your tibia, the shin bone, right in the middle of your knee, connecting to the femur. Okay, so now inside the knee joint, it's synovial fluid. That's your joint fluid, the thing that lubricates your joint. Now, and the ACL tears right in the middle of it. That area is fairly avascular. That means the blood supply to the area is quite poor. Right? And like if you don't have blood going into a certain part of your body, it's never going to heal. That's why you have problems with diabetics, where they have vasculopathy. They don't heal very well. It's one of the reasons. So anyway, so the ACL doesn't get its blood supply. It doesn't really heal well. Okay, and that hence why people with ACLs tend to get a lot of problems. At best, sometimes you see the ACL tend to scar itself on another part of the knee in a suboptimal fashion. And the patient is generally left with that residual instability or that giving way problem. And now, again, can you treat this non-operatively? Actually, you can treat anything non-operatively, and you have to be careful with who you treat. So, who is a non-op candidate for ACL? Again, as I said, because the ACL doesn't heal very well, its function is compromised, right? Now, and if you look, how do you then, make use of your knee as well without this main structure not working? Okay, so there are some studies that have shown that if you really rehabilitate someone, there is a small proportion of those who may be able to get away with it. All right, but by and large, the answer is no. It doesn't heal well. It doesn't actually solve the problem. Patients get this, this residual instability, and that in itself, remember, it's not. Let's not just think about instability. We are thinking about the consequence of that. So if you are left with an ACL that is torn, you subject yourself to other problems. And that's even bigger. You're talking about tears to your corresponding meniscus. It's a specialized cartilage. It's like I call it a shock absorber. It's like a gasket within your knee. It keeps the stresses between your femur and your tibia in check. Now, we know this according to studies. You don't have a working ACL, chances of you tearing your meniscus, especially your medial meniscus, is much higher, especially when you delay it or you leave it. You don't have a functioning meniscus, stresses are high, your cartilage is now subject to a lot of stress, and you get degeneration and damage to your cartilage, eventually arthritis, right? So to answer your question, if you want to treat it non-operatively, I don't know, my personal take, maybe I'm biased, I'm a surgeon, I love the ACL. But if I tore my ACL, I'm a weekend warrior. I play a little bit of badminton with our anesthetists and friends. I'm not good at it. I would still fix my ACL. I wouldn't fix an ACL in someone who's like 75 years old, who doesn't do any sports. His activity is limited to going and watching TV and at best going down to a village grocer. But if you are anyway healthy, especially, and now conversely in a younger person, if someone who's in their 20s, they tear the ACL, I'm very aggressive when it comes to that. I don't even want to. I don't think I would let my son, if he was 20, to be left without a working ACL, solely because I want to maintain not only the function of that ligament, stabilizing knee, I want to avoid that effect on the rest of the knee structure, meniscus, and avoid that degeneration. I don't want arthritis happening in someone who's 20 within the next 5-10 years, if I can help it, given the technology we have. All right?
Okay, Doc.
So that's non-ocular.
Okay, since you have mentioned, right, if it's not treated, then it affects your stability. But if someone is in their 60s and all and still, I would say healthy, but due to this ACL injury, do you still recommend them not to proceed with the surgery? I mean, it's affecting their stability.
Good, yeah, no, actually, and you're right. And that's why you shouldn't, by the way, we are Malaysians, I don't know why we always think age is like, oh my God, auntie is really 65, knee double A. Age is a number, right? We are looking at, and we are now in 21st century medicine, it's personalized care. So you take the patient into account. You can be 65, well, what did you say just now? It's only 70, yeah?
60.
How old is your, okay, 60. You have a 60-year-old who is abseiling and doing rock climbing, okay, and he plays badminton twice a week. His knee is overall well with only grade 0 to grade 1 wear. I think it'll be criminal of me not to reconstruct this ACL.
Okay.
You get what I mean?
Yes.
You treat your patient because of the symptoms he complains of, his potential of reaching back, his pre-injury status, and and that's how the practice of medicine make the patient better. Now, if you look at say, okay, now you take say somebody who's older. Now he's got arthritis, say, okay. Now remember, you have a old. Well, I'm sure you know a few. I hate to use the word old. Mature persons who have arthritis in their knee. By the way, with arthritis comes a lot of capsular fibrosis. Big thing that arthritic people complain is stiffness. Now, when you are stiff, actually, you are stable. A stiff person is not loose. You understand? Your arthritic people generally don't complain most of the time. Not all, but most of the time don't complain of instability. It's the stiffness that they complain of. So, if you have very severe arthritis, you're talking about 75-year-old, severe arthritis, very stiff. Now let's assume he fell down from a chair and now he tore his ACL, now it's even worse. See, that's why you need a thinking surgeon, Yes, don't go read the MRI. The MRI shows, yes, there's an ACL there. However, look at the background picture. You got no cartilage there. Your knee has been bad for many years. What are you doing replacing ACL? Don't. So replace the whole problem. If somebody came with me like that, I would do a knee replacement. Okay? Solve his main issue. With a knee replacement, they are, well, I won't go into the mechanics of it, but they have inherent structures built into modern knee replacement that mimic the function of an ACL to confer that stability.
Interesting. So which I can summarize that ACL from the previous question. I can summarize that ACL does not heal by itself.
Yeah, the ACL by and large doesn't heal by itself. It's not
okay. So what happens if I opt not to fix my ACL problem?
So if you don't fix your ACL problem, now I'm not going to ask your age, Sony, but I'm going to assume you're quite young. Right? You don't fix your ACL. You're going to be left with some residual instability, the giving way. Okay, now initially you'll have that. You may have other problems like locking, clicking, pain. Alright, with the instability comes the inability to function. If you are, I don't know what you do. So if you play sports, you're going to have some problems. I don't know, dancing is going to be a problem and things like that. Now, if you don't fix the ACL, you're going to have most likely going to have other problems. You're going to be risking injury to your meniscus, your soft absorbers to your knee. You're going to risk wear in an early onset degeneration. Degeneration of cartilage is a nice way of calling, saying the word arthritis. Okay, so you predispose yourself to that. Okay, so I don't know. Long story short, that's why when you take yourself as a whole, you kind of have to understand what does it do, what am I, how much do I function, do I want to be, left with kind of loose knee, okay, with all these problems. When conversely the what is this? The converse of it is, to get it sorted. I can fix this. I can fix this problem. It is a problem. I can fix it. And the success rates of this is so high. So why would you not? So that's the logic I subscribe to.
Okay, but I have seen it. I have seen in my circle those who have went for knee surgery. They have issues with bending their knees, and then all those things. That's a lifelong effect, isn't it?
That's right. So you're talking about before or after, because it happens in both.
I thought it has. Does it have this after the surgery, or it's only before?
You can, and see, this is the risks, right? Before surgery, if say you don't do surgery, somebody injures themselves. Very important, you don't keep quiet after injury. Of course, you let the swelling all settle, get the pain settled. But once you do that, if as I said earlier, even if you opt not to operate, my God, you have to do a lot of rehab. You really have to push your knee. What is the function of the knee? The knee is to, of course, you need to walk, you need to move. The knee functions by moving, range of motion. You need to get back that range of motion. All right. The knee functions using the muscles around it. Okay, bilateral. So there's all these muscles, the quadriceps, the hamstrings, the gastrocnemius. All these must be working. All right. It's actually what you say is very common. You get a lot of people complain a lot of stiffness after. I've seen neglected ACLs after 1-2 years where the knee bend is only about 20-30 degrees. It's like almost a functionless knee, and the patient is only 22-23. Now, why is that? There could be a failure of recognizing that there is an injury, the patient needed physical rehabilitation and it's not sent, a little bit of miscommunication between the healthcare provider and the patient, a lot of things. And that's why actually, and again, second thing, can this happen after surgery? Actually, it can. And that's why it's very important that even if you do surgery, surgery doesn't just end the picture. Surgery is almost like 60% there. You still got a lot of way to go. You need your physical therapy, you need your rehab, you need your, you actually, the patient needs to put in the work. A lot of the work is actually done. My patients, most of the work is actually done at home, with the physiotherapist kind of monitoring and adding to it. And I am in constant communication with my physiotherapist. Actually, our physiotherapist upstairs. Very good. They have my number. They disturb me at night. But it's good. Disturb Dr. Gandhi, my 125 degrees he plays for this club that club this fellow Malaysian player how Yeah, I know. That's the importance. You need the physical therapist to push within limits of safety to achieve their pre-injury level of function. That's the whole endpoint of the game. So when you're coming back to your friend who injured himself, there's so many reasons. Was it neglected? Does he have a structural problem in his or her knee that limits her range of motion? Did he comply, or he or she comply with the post-injury or post-surgery rehabilitation? There's a lot of things. And that's part of the consultation. You need to see a doctor. Your doctor should be able to tell you all this. And you be informed. Importance of communication, isn't it?
Yes, I agree. So, but I'm still with the same question. So, roughly, How long does the entire process take?
Okay, no, good curiosity. I'll give you my normal patient. Patient A, suddenly decides that I'm Lee Chong Wei, smashes like a champion, and tears his ACL today. Now, okay, I'm talking about gold standard. This patient would be seen, if he knows me, okay, so he's seen within 24 hours, gets his MRI, there's an ACL and a meniscal tear. It's a very common presentation. Okay, nowadays I'm quite aggressive, especially in high functioning athletes. I fix my ACLs as earlier the better. Now, if it's done, the patient wears a brace. Patient's walking actually the day of surgery. So if I operate in the morning, by evening he's walking with one crutch. I have stopped non-weight bearing my patients. I get my patient to walk straight away with the brace locked. So there is a protocol that they need to follow. And they're moving their knees straight away. Gone are the days where we put patients in cast and all. I don't think any sports surgeon does that anymore. After 6 weeks, the brace is off. Actually, most of my patients, again, crutches, it's 2 weeks. I got footballers who don't even use a crutch from day one. So normally by about 2-3 weeks, the crutch comes off, brace comes off for about 6 weeks. But mind you, you still take care of your knee. Right? You're doing a lot of exercises in the meantime. Around 6 weeks, if you are working in an office, a place where you need to walk around, generally you can go back to work around 6 to 8 weeks. And then at 3 months, you can 6 weeks, you can start cycling. Okay, depending on how good you are, you can already start stationary cycling anywhere between 2 and 6 weeks. At around 3 months, I expect my patients to be able to do treadmill running. Actually, most of my athletes, but straight line running, and again, running, a lot of people think, I know I have, Dr. Gandhi, I got a half marathon in 3 months. I said, sorry. Okay, no half marathon, no. Straight line running, very careful, guided, on a treadmill is safe, okay? There's shock absorption and somebody to monitor you. Now, you're talking about full function, okay? So now you're talking about the athletic population, high-level athletes. Actually, within 3 months, they go back to their structured agility, sport-specific rehabilitation at that roughly around 3 to 4 month mark. Going back to sports normally takes anywhere between 6 to 8 months. So if I have a player I cannot tell the name of the football team, but if they are a first team player and they really need him back, I tell the coaches straight away, it's a minimum of 6 to 8 months depending on how well the patient does. You can go back to work, no problem. If a weekend warrior like me wants to go back with his friends playing badminton, I will still wait 6 to 8 months. Okay, so it does take that long for the graft. Surgery is adding a graft to reconstruct or to replace your ACL. It allows for proper ligamentization, to the graft to change and become a functioning ligament. It does take that long. That's why we wait.
Interesting. That's quite a long period also to wait.
Actually, that's true. And a lot of people don't, a lot of people, I suppose, nowadays, modern days, everything must be fast. Yes, it does. And it is not easy trying to convince, especially young player, 18, 19, and this, I actually had this one. A young guy called up the Malaysian under 19 football team. Okay, and I'm telling his parents that sorry, you can't join MSN. You need to rest for 9 months. It's difficult to take. And unfortunately, here comes other people saying that, don't worry, we can rehab you and you'll be fine. And yeah, sure, he goes back and then he re-injures again. He's unable to go back. Now, if you look at it, I let's not talk about the sad stories, but there are some harrowing stories of young fellas. I'm talking about 18, 19-year-olds done this, neglected. Where they get their information from. By the time I go in, it's already 1-2 years after surgery. Their knees are, So anyway, importance of communication. You need to make them understand. This is, the simple thing. You need patience. You're not going to be in bed in a cast for 6 months. No, but you have to be careful. Patient, mind you, when you say 6 months only, 6 months means I'm not playing on the field. I'm not keeping quiet. I'm in the gym. You're in the gym day 1, day 2 after surgery, doing very graduated, specific, prescribed exercises. Yeah, exactly.
Okay.
So you don't keep quiet. You are there. Like if you are a professional player, you are working.
Okay. So to my next question. So what do we do, or what do I do if I have if I tear my ACL? What is my immediate action? I mean, obviously, because as a person, I wouldn't know if I tear my ACL.
Yeah. So, good question. So the young viewers out there, if you tear ACL, as I said earlier, what are the symptoms? Number one, you'll hear that. Most of them hear or feel that pop. It is kind of dramatic, in the field, in holding your knee and stuff. So the first thing is control pain, control swelling. That's your first goal, first point of action, right? So let's talk about all of them in detail. So on the field, or just like the first 1 hour, 2 hours after injury, things you just rest the patient. Don't let them put weight on it because that causes pain. You give some ice or a cold pack on the knee. That helps a lot with pain relief, helps a lot with the swelling. Some patients have the ability of getting proper compression bandages, things like knee guards or even those bandages. All that is to help compress the knee. It tends to immobilize the knee to an extent. And the other important thing that you can do is, and I teach this to the first aiders and the sports physician guys, right? So when you're on the field, make sure the leg is elevated. Keep the foot up. There's two reasons for that. When you injure your knee, your knee tends to go into that kind of position, the 20 to 30 degree flexion. That's for comfort. While it's comfortable, it is in any case, I prefer it elevated. It lets gravity to help with the swelling. Okay, so it comes down a bit, and also helps with extension. Okay, so those are the first few things that you can do when you tear ACL. Rest it, ice it, compress if can, and elevate it. Rise. Okay. Next thing is painkillers. So normal over-the-counter painkillers are fine. Things like Panadol. Panadol is very common. Some people have access to non-steroidals. Things like Ponston, ibuprofen. Things like that. That's more than enough. Please don't be very severe cases associated with multi-ligament injuries, fractures, and stuff. Some people even use opioids. But anyway, get the pain under control. So once you've done your ice, once you've done your pain under control, get help early. Okay,
so
sitting down.
After the swelling is down, the pain is in control. That's when they walk and meet the specialist to check.
Yeah, exactly. See, you injure. I think no more in 1970s lah. we got a lot. We have the medical expertise available, So I don't understand why people wait. You wouldn't wait if your car, you broke an axle of your car. You wouldn't keep your car in your garage, wait for like 2 weeks and then start it again and see whether they can drive or not. You take it to the mechanic. I don't know why some people don't do that with their knees.
I think it's just the generation where they don't take it seriously on injuries, and they expect the recovery overnight and they'll be fine,
Yeah, that's like right. And then sometimes we got Dr. Google. So
yes.
My God, the nonsense you see on WhatsApp. Some of my patients actually send me, the special, I cannot say the word, this doc swear to you, this therapy, the fella, I said 3 months and I can play football again. I said, really? Like if that therapy were true, he would have won the Nobel Prize for medicine. 1 million ACL surgeries are done a year. ACLs are very, very common. In Malaysia, if you just look at the incidence, if you look at American numbers, Malaysia, anywhere between 15 to 20,000 ACLs are injured per year. It's a lot. Right? Now, if they can find a special, therapy that heals it, my God, great, The fact that we don't have that, the fact that surgeries are done, that should ring some bells. Anyway, get help. Go and seek help early. Now I tell you why, Sonia. Now I think, and in the past, there was this idea. You tell your ACL, actually don't operate first. Really, when I first started in orthopedics, the classical teaching was do not operate on an ACL early. Reason being is they were worried about stiffness or arthrophytosis. Right? So now, what we used to do was we send them physical therapy, get them moving, get the swelling settled down first, and then do their operation. Now, there are a lot of surgeons that still do it, and I don't think there's anything. I'm not saying it's wrong or anything like that, but there is now a shift in opinion. Okay, especially in a lot of sports surgeons. Myself definitely included. Over the last, how long have I been a sports surgeon? For maybe about 10 years now. Definitely over the last 4 years, I've changed. So my paradigm now is to operate early, and there's a reason for it. I see a lot of concomitant injuries with an ACL, especially the meniscus. So I do feel that the earlier you fix the meniscus, the better your shock absorption. And we know through studies that meniscal repairs that are done with an ACL reconstruction together are much, much more successful overall. Right? So that's one. Number two, as I said, ACL takes around 6 to 8 months to heal from surgery. So if you take someone who's injured, you leave them unoperated for, I don't know, give it like 2 months, 3 months. You have to add that 2 months, 3 months to the 6 to 8 months. So it'll come up to a year.
Yep.
You get what I mean? There is that obligatory downtime. And the third and more important one, I think, is remember, and especially high-level athletes. High-level athletes, look at their legs, and they've got very good muscles, strong, solid, functioning, and these, not only is it just size, it is a lot of neuromuscular coordination and skill that has been trained and evolved. All that, if you leave it unoperated, you will lose it. You will lose muscle bulk. So to minimize that's why my personal feeling is, get this early. What do you've got so much to gain, not really much to lose by operating early, provided you follow the, post-op rehab. Now you have to be compliant. That's my personal philosophy of ACL. So, yeah, I got down. I know skiers. Took a photo just before COVID. Showed me a photo of myself skiing after ACL. And that was 7 months from injury. So operated and then went back. So you think about it, then you find it hard to convince yourself to do otherwise. Why would I wait? And probably much better results if I do earlier.
Okay, so speaking of ACL surgery, what actually take place in the surgery?
Yeah, so that's a good question. So ACL surgery, okay, so let's assume patient comes, seen, assess, talk. You have to communicate something. MRI confirms it, so you're going for surgery, right? So we talk about the surgery. So what happens for the patient? The patient's journey is, he gets admitted. Okay. In my hands, normally it's they have surgery on the same day as they are admitted. So they come in the morning they are brought to OT, they come in fasting, right? They're seen by our lovely anesthetist who puts them to sleep. So most of my ACLs are done under general anesthetic, so we have only ACL. So now the surgery proper. So the surgery in itself, if you simplify it, what we are doing is, the two bones I mentioned earlier, you're trying to put a graft between the two bones, connecting the two bones. Okay? So the way we do this is we drill a hole in the femur, we drill a hole in the tibia, and we put this graft. Graft is this tissue that we use specifically to replace the ACL that is torn, and then over time that ligamentizes and becomes an ACL. So the graft tissue, there are many choices. So common choices in Malaysia include the hamstring tendons, the patellar tendon, the middle part of the patellar tendon, quadriceps tendon, some people do. I've also heard of surgeons using peroneal tendon, and another one is allograft. Allograft is donor tissue used from cadavers and stuff. And they all have their pros and cons. My personal choice is the hamstring. So I harvest the hamstring graft, and then we do the surgery. Now all this is done. There's no opening. There's no cutting. Everybody has this notion in their head. I have to cut my knee from top to bottom. That doesn't exist. Nowadays, it's all minimally. My hamstring, that's my incision site to remove your hamstring. My key, it's all keyhole, right? So the portal sites are about 4 to 5 millimeters in length, and you do the whole operation through those incisions. Okay, takes about an hour. So once it's done, and you secure it with all the very, very high tech buttons, differential screws, and then you put in a brace. So the whole operation takes me about an hour, 1 hour, give or take. The good thing about surgery is, remember, you're doing operations, so you're replacing. You are also there to see the whole knee. So any time we know that there is tears of the meniscus that commonly occur, which is very common, and then I tend to fix it there and there, because I know that fixing it gives it so much more better chance of it healing, and so lessens the chance of future problems. Right. So you do all that, put the patient in a brace. Okay, after about so in and out from OT, normally about 2 to 3 hours, the patient's back in the ward. Then our friendly physiotherapist comes, and not so friendly actually, forces the patient to. The patient is just about waking up, and it's like, Dr. Gandhi Nathan, but it's for your own good, right? It's a necessary evil. So they start moving the knee. Okay, there's a range. That's why we use the brace. It locks it within a safe range. They teach them how to extend and lock the brace so that they can walk. So we teach them how to walk with one crutch. I don't use two crutches, I use one crutch. And most of them, actually about 80%, 90%, they are walking on the same day. So that means operation at 9 o'clock, by about 3-4 o'clock in the evening, they are walking around the ward. Ara Damansara, we keep them overnight, just to make sure the pain is under control. And then again, like I said, 97, 98% of my patients go home the next day. So the whole process is about 24 hours. Go home, and now they go home not to relax. They go home with a specific set of exercises to do, and including including moving the knee, getting their range, strengthening the muscles, getting their gait, walking properly and safely, and stuff like that. Alright, so that's the surgery.
Okay, what if they don't do the exercise at home or overdo the exercise at home? What happens?
Very good. So you don't do the exercise. So these are issues of compliance. And you see that. And it's actually quite easy to see that, because remember, Shakira said hips don't lie, your muscles also don't lie. Your quadriceps go into wasting. Right? So you do waste away your quadriceps if you don't use it. Similarly, your Newton's first law, body at rest tends to stay at rest. Your knee, if you don't move it, stays stagnant. You don't achieve automatic movement. Remember, surgery and the ACL that tore it is traumatic to the knee. And when there is trauma in your body will tend to scar itself. So hence the importance of moving. Okay? When you move, you avoid that scar tissue forming that restricts further movement. Right? So that's why it's very, very important in patients to gradually move within, and this is all taught to the patient in a very safe manner. How do you move it? At what range can you move it, depending on what is done? All right, and how to progress further. So normally, they achieve 0 to 90, or most of them almost immediately. But my target is like 0 to 2 weeks to 90 degrees. Okay, 2 to 6 weeks, they slowly progress to achieve their full flexion. Right? And then only we take out the brace. And you said, the patient that doesn't do it. Normally you can see it at 6 weeks, they are weak. They can't even move their knee up. And it's very easy to see. And that's why, and you just have to stress them, because surgery is about 60% of the way. 40% is the patient's own work. The physiotherapist will help, and they are very important, but discipline. So, and I'm also, I'm being trained to, not scare is probably a strong word, but you kind of have to put the fear in the patient. I had one girl, hope she's not watching, but post ACL.
Okay.
Oh my God, at 6 weeks, she barely could move because she had about 0 to 30 degrees. Now, for a surgeon, that is unacceptable. Well, for me, I'm OCD, so completely unacceptable for a sports surgeon. I was threatening her to bring her back to OT, because if you do, then you have scar tissue forming. You can't just, that thing is miraculously not going to disappear. So we have to do things like, manipulations, re-scope, re-arthroscope, rebride, and take away the scar tissue. It's a horrendous thing. I think that scared her enough. She changed the physio, went to our friend Brian here, who also scared her a little bit. 3 weeks, and 3 weeks brace off, smiling 120-degree flexion. It's you see the important, and you know what? It's nobody's fault. This is a communication thing. The patient needs to understand what he or she needs to do, how much he needs to do. This has to be brought forward. And when they understand this, they tend to do very well. So there you go. And what was the other one? If you do too much, is it? Yeah, do too much is also, you see that mostly in the younger guys. And doing too much, they're normally quite good with the brace. The too much is, when we tell them not to play sports, right? And that's the problem. So they go, because by 6 weeks you're very comfortable. Your leg is almost like normal, you're no more with your brace. And then imagine you're a 19-year-old boy, and then all your friends are in the basketball court, and they throw you the ball and just do one layup. I remember being 19, so it is difficult to say no, yes, and they can. If you do too much, you're not compliant to the restrictions. Remember, your graft is weakest around the 2 to 3 month mark. That's when it's weakest. Ligamentization is a big. I won't go into the process of ligamentization, but that's when it's weakest. You are very. You require your muscles to work in coordination to protect it. But if you do silly things like jumping and running and twisting on a weak graft, and you are bound to put yourself into trouble. And then you can rupture it again, and that's a problem. We need repeat surgery.
So repeat surgery is possible. Okay. My next question: what is the risk of having this surgery?
Okay, so it's surgery, so there are a few risks. Anytime, like this is the risk for any type of surgery, right? The risks are, you cut your skin, there's a risk of infection. Okay, the skin is all of us have commensals and bacteria on our skin, so there's a slight risk of infection. Hence, why surgery must be done in a proper, sterile OT, antibiotics given, and there's a whole rigmarole in theatre to ensure sterility. Right? So there is a risk of infection. There's a risk of neurovascular injury, nerve injury. Now, very uncommon to get massive nerve injuries. Touch wood, never happened to me. But you can get a little bit of numbness around the area of the incision sites, and most of that very transient. Mind you, Sony, all these risks I'm saying is less than, I see less than, in my hands, I think about 3%. Okay, it's rare. So the other risks are pain, okay, and stiffness. All right. So you need to get the patient up and moving, get their muscles, the joint moving as early as possible to avoid this, and also adequate pain relief. Now there is a specific risk of ACL, and I think we touched on it. It is the risk of re-tearing it. So the ligament that you have done, it can tear, and the risks of tearing, re-tear, re-rupture it's called. So these are much higher in young males.
Okay.
Now there is
aggressive and stuff.
Yeah, exactly. So that could be a factor. It's not just young males that are at risk, right? There are other risk factors. There's certain things that was not identified before. If there was a notch osteophyte, or if the patient's own anatomy, the notch is very narrow. They have a malalignment issue, the ligamental laxity issue. There's a lot of things, right? That can predispose not only for you to tear it initially, but tear it subsequently. So these are, and now the risks. The risk of re-rupture for the general population is quite low. It's I would say it's less than 10%. Okay, the success rate of ACL is 90-95% in most cases. So the risks of this drop as your age increases. Okay, so that's good luck. Slightly older you are, the better your re-rupture is.
So
those are the main ones.
Okay, my next question. So how many times can we perform this ACL surgery if, let's say, it tears after the first time or second time?
Okay, well, I'll tell you, my boss told me, you do enough of these ACLs, it's going to happen to you, and it's true. Okay, how many times can you do it? There's no real figure there. I think in myself, I have I was person number 3 to do this, and then mind you, by the time I'm doing the third time, this is complex. 2 other surgeons have gone before me. I'm going for number 3, and for that patient, it was a 2-stage. Where I have to. It's complex. I have to graft the tunnels. There was another issue that we had to address at the same time as another ligament that we had to fix. So then, technically speaking, there's no limit. So I'm sure around the world, I'm sure there are people that have done ACLs like 6-7 times. However, remember, the more times you do surgery, your success rates drop. So, of course, the re-rupture of the ACL, that itself is bad. However, it's not the end of the world. The successful outcomes after revision ACL surgery is actually quite good. It's anywhere around the 80% mark. If it was a primary ACL, I think the success rates are around 90-95. Even revision surgery, your success rates are around 80-85. Now, the different surgeons are different. They have their own protocol. I have my own. I tend to not only replace the ACL again. It is getting very technical on how you do it, but let's not go there. But I normally add another procedure as well to strengthen the repair of the construct and protect that ACL graft. Long story short, if you have ACL surgery before and it tears again, it's not the end of the world. There are a lot of things you can do. You can reconstruct it back again, and hopefully, all going well, you will return to your pre-mortem function.
Okay. So, Doctor, I'm going to pick up some questions from the ground. So, we have one here from Miss Lupikli. So, she experienced low pickly.
Oh, okay.
Yeah. So she experienced this pain and the feeling. So the question goes like this: I experienced this pain and the feeling of my right knee cap is wobbly sometimes. I jog and I do Muay Thai regularly, but I don't remember injuring myself. Does it mean that I could be doing this exercise wrongly, or it is something to do with this ACL?
Well, good. You're asking me to diagnose just like that. A bit difficult. Diagnosing ACL, you need a proper history examination. Now, kneecap wobbly, is that patella instability you're talking about? Okay, and that is a common thing. You can get loosening of your patella. Patella is the kneecap, right? For many reasons. A common one is previous dislocation. You can get things like chondromalacia, that is wearing of the cartilage below the patella. Common thing in women, especially athletic women, I see it. So there's a lot of things that can explain why you have that pain. Could it be the ACL? Just, my God, just very brief. I'm sorry, my opinion won't carry much weight because just very little info there. But yeah, if you're worried enough, you should get it checked. Could it be ACL? Hard to say. I have to examine you first and see.
Okay. So, all right. Thank you, doctor, for that. And then my second question, the second question on the ground sounds this way. I tore my ACL during kickboxing when I landed wrongly and twisted my knee. Had aspiration done, but no surgery. Just started rehab. Would like to go hiking, but trail is mainly uphill. Advisable to go? When can I start activities such as this?
Okay, good. So now again, when you tear ACL, I assume you were seen and the ACL was not torn completely, was it? Let's assume that is the whole.
Okay, yeah.
So it's like, the ACL, you can have partial tears of the ACL, not complete tears. And in those patients, yes, I myself, and on examining, if it's not loose and stable, yes, I tend to let them, just do rehab without surgery. So how long should you do surgery? How long should you do rehab before hiking? So the best judge of that is actually the patient itself. So you attend your rehab, go for it, and the rehab is not just, I attended physio and finish. What was done? What was the goals of that rehab? Were you trying to improve your range? Were you trying to improve your muscular strength? Rehab, you must understand there's a lot of things. You don't just say physio and that's it.
Yeah.
What are you trying to achieve? You have to give those proper instructions to the physio. Now, if you're a hiker, okay, there's certain things that you need. You need your quadriceps to be solid. Okay, you need to be able to be, landing and going up, 1-2 steps, right? Comfortably, especially descending step. You should not have any instability, because the last thing you want to do is go inside the jungle and then suddenly have a wobbly knee. You're gonna have problems. So all this can be tested not only by a physical therapist, but definitely by your orthopedic surgeon. And if you feel confident, by all means. And then before you go hiking, do smaller things. Go on a small trail somewhere close to your house. Go up a little hill, come down that hill, see how you are. If you are comfortable, then okay, let's take it further. If you are uncomfortable, don't be a risk. Yeah, exactly. Yeah. Just be sensible about it. No, seriously. I'm not making fun of anyone, because I'm also a bit of a chancer. But yeah, if you tearing your ACL, it's no joke, right? If you really have a full tear and you're young, okay, and mind you, that's my philosophy, right? I am aggressive, and that's just me, because I think that having a intact ACL is, any day better than having a deficient ACL. But I rehab myself to kingdom come. So, however, I also know that there are some patients who have torn their ACLs and still done very well without surgery. There are some athletes even. They are very rare. Very, very small proportion, but they have. So, it's not a zero-sum game. Some few people will get away with it. But I think by and large, most patients, I think, do much better with an ACL reconstructed rather than having it just left there.
So, Doctor, we have almost at the end of our session. So, before we end this session, I have one more last question. What is the aftercare like following the surgery?
So, aftercare, the early periods of aftercare is, of course, taking care of the wound. Normally, it's you put a little dressing on it, it's waterproof. You're allowed to shower and all, but you don't remove the dressing. You allow that to heal for about 2 weeks, and after 2 weeks, the dressing comes out. You don't stitches. I think nowadays I don't use any sutures anymore. It's all dissolvable. The things that you have to be very, very careful are make sure you're compliant to the physio regime, move it, do your exercise daily, ice it, elevate it, make sure you wear the brace. I tell my patients to wear the brace to sleep. Okay? So things like that. Alright? That's the aftercare. Now, after 6 weeks, okay, you follow your exercise, this protocol. Like for my patients, I have a very, very specific thing to follow. What exercise I can do, what exercise I cannot do, what to avoid doing. So at around the 6-week mark, they're all free, independent, but they just follow this. They avoid certain things like open chain exercise for a while. At about 3 to 4 months, you can already start inline jogging, inline running, as long as it's comfortable. Those who are, if you're like a high-level athlete, you may want to see a proper sports physician or a proper physiotherapist. You do agility testing to see how you are with cutting and pivoting moments as you continuously strengthen your legs. Oh, mind you, just a simple thing about aftercare, and this I have heard about it, I haven't seen it yet. Everybody's so focused about exercises on their legs, right? Because the knee was operated. They just exercise the legs. And one problem was, doctor, I gained 5 kilos. Right? So, now, well, it can happen because, you're not as active as you were, especially in the first 2 to 3 months. Aftercare also includes taking care of the rest of you, So, make sure you have a good diet. Vitamin C is good. Okay, so I had that. Make sure if you're talking about exercise, I could speak all day about exercise. I'm a sports guy. So not only are you exercising your knees, your quads, your hamstrings, your calves, your foot, your hips. Don't forget your core strength, your lower back, your upper body, things like that. That one doesn't stop. That's why I say a lot of athletes, especially professional athletes, see me, they think, I have an ACL MC 2 bulan, I can go back to my kampung. No, man. You, at best, you're 2 days, 3 days at home, and you're already back in the gym. So, things like that. Once you finish your... Okay, now this is for higher level. Once you finish, say, 6 months, 8 months, 9 months, back in the field, okay, there are actual exercises to keep on doing continuously. I think there are certain countries in the world, like Germany and Sweden, they actually have this program for their junior athletes, right? And it's all FIFA, the International Football Federation. There are these certain exercises or drills, they call it, that actually help with the neurovascular coordination in an attempt to reduce the likelihood of further injury, okay, or re-injury in this case. So those kind of things are there. Aftercare is important. Please don't just think, I've done the surgery, okay, everything is done, thank you very much, bye-bye. Be very cognizant that your success is very, very much determined on how well you get compliance.
Okay, doctor, so we are at the end of our session. Thank you so much for the knowledge sharing. So if we have any question further from the ground, we'll definitely post it up to you and look for your explanation, and we'll share it up on our social media. Thank you so much, doctor, for joining us.
Thank you, Sony. All the best, sir.
All right.
Thanks for having me. Bye-bye.
Bye-bye. All right, so that was today's Facebook Live Forum from ADMC. See you again next month. Bye.